Hello, House Psych students. You have now entered part one of the pain lecture. So let's get going. Let me pull up that PowerPoint. I hope everybody is doing well. I hope everybody's staying safe, sanitary, and nobody's sick. All right, so we are going to mainly talk about chronic pain, but before we do that, we're going to talk about how pain functions. So let me get this pulled up for you. All righty, pain comes from the Latin term meaning penalty or punishment. I think that the roots of the word will make sense to many of us in that regard. And I want to first establish that pain is absolutely necessary for life. We have evolved to feel pain for a variety of survival reasons, because pain signals to us that our body is in danger in some way. And so it calls our attention to wherever in the body we're feeling pain, so that ideally we take care of the problem. So I want us to think through a couple of the reflexive things that we tend to do that are protective behaviors that a lot of us do without even thinking about them. That's kind of evolutionary. It's our instinct. So you touch your finger to a hot stove. The reflex is you jerk back very quickly, and that is adaptive, because if you touched a hot stove and it was burning, and you're like, oh, well, it's kind of hot, man, and you burn your hand. So reflexive behavior there. I want you to think about, like, let's say you have hit your funny bone. What are you going to do? Are you going to go around flinging that joint that has been potentially injured, flinging around, endangering it more? Nope. Most of us, when we do that, we would grab it and hold it nice and tight and hold that joint still. I want you to think about what happens if, I'm not going to do it, but if you got a paper cut, most of us do this really weird thing. And make sure you wash your hands before you try this at home, considering coronavirus. But we would take that paper cut and we would put it in our mouth. And there's a couple of things happening there. It's kind of gross when you think about it, but we are licking that cut in case there's any debris in there, particularly debris that is spurring bleeding. Then we would be cleaning it. But then there's this other thing, particularly with the paper cut, and I think most of us would agree, if you've ever had one, you get this really stingy sensation from a paper cut. So it's a very different sensation than, say, feeling a burn if you've got your finger on a hot stove. But oftentimes after we're kind of cleaning it for debris, we're sucking on it. And interestingly, the sucking sensations oftentimes make their way to the brain and override the stinging feeling. So part of the reason why we put it in our mouths is to clean it, but we're also creating a different sensation that actually helps to override and stop, in a lot of cases, that stinging sensation. So again, it's all instinctive. It happens naturally. Okay, imagine you've got a muscle that's really tight. And then we tend to kind of rub that muscle, or if it's a really tight muscle, like a neck muscle, that kind of thing, we rub that muscle, and a couple things are happening there too. If it's a really tight muscle and we rub it, we massage it, a lot of times we help that muscle tension release. And so if it's really tight, it can release and feel better. But what we're also doing in that sensation is we're sending very soothing feelings that make their way up to the brain that sometimes start to override some of those tense feelings coming from that muscle. So I want us to kind of acknowledge that pain is necessary for life, that a lot of us have these very instinctive, natural responses to pain. But when you think through the mechanisms, they actually, they have some function, those things that we tend to do. So pain is the most common symptom of disease, and they are some of the most common over-the-counter medications that we consume in the United States also. But as the most common symptom of disease, that also kind of reflects the fact that pain is necessary for life. If you recall in the cardiovascular disease lecture, we talked about how hypertension and high blood pressure is considered to be the silent killer. And it's a silent killer because people don't feel pain from it. It's not like you walk around and you're like, whoa, something's wrong. I think I have high blood pressure. I need to take care of it. A lot of people are out there walking around not even knowing that they have it. So that's one of those examples where we can't feel it, so we don't attend to it. So here's our textbook definitions for pain. Pain is the emotionally disabling sensory discomfort, usually associated, not always, but usually associated with tissue injury. And there are two types of pain. And so we're going to cover acute pain, but what we're really going to focus on in a health psych course here is what we do to deal with chronic pain. So acute pain is either there's an active state of disease or injury. So you've got strep throat, and then you've got throat pain because you've got strep throat. That would be active disease. Usually there's damage there. Usually the damage can be seen. If it's on the outside of the body, we can see the damage there. If it's internally, there's damage. There are different scanning techniques that medical professionals can do to see the damage internally. But with acute pain, you can normally see it internally or externally. And oftentimes acute pain just simply goes away when the injury heals. So imagine, you've really hit your arm and you've got a nice bruise on your arm and it hurts, or when you touch it, it is sore, tender. When that bruise heals, you're good and there's no more pain, no more issue. Chronic pain, on the other hand, which is what we health psychologists are much more interested in, is when there's pain that continues after the injury heals. So 6 or more months is just kind of our rule of thumb of pain that continues once an injury's healed, but the pain's still there. You can get chronic pain from a chronic medical condition. So certain cancers will spin out chronic pain. You could have certain injuries to the discs in your spinal cord and your vertebrae. That could be chronic pain because there's a chronic medical condition happening there. Sickle cell disease, which is a disease, a recessive disease that runs oftentimes in African Americans, a very painful blood condition. And then the last kind of pain, which a couple decades ago, the medical professionals absolutely didn't believe in this. And it really wasn't until we had these pain specialists in medicine, until we had enough psychologists interested in chronic pain, that now we kind of find pain that starts out of nowhere without an injury or an identifiable disease state. We now believe that to be true because we have studied this in enough individuals, and we also, at times, researchers consider this to be kind of fascinating, of like, how could this be happening in the body? I don't know if you remember in the New Medicine documentary, there was a young woman who played softball, and she's featured at one point in time sleeping on the couch. So she had after a normal kind of illness, like a flu type thing, she had chronic fatigue. She looked very depressed, and then she was reporting chronic pain all over her body. And then if you recall, the psychologist that worked with her trained her in self-hypnosis, and her chronic pain was able to go away. In her situation, she first has illness goes away, but then she has chronic pain that persists. I've even known individuals where, let's say, they have an injury to their knee. Okay, so just one body part, and even the knee injury appears to heal, where now they will get pain all over their body, like chronic fibromyalgia, achy kind of pain, like the achy kind of pain that we oftentimes get with a fever from a knee injury. So all kinds of different types of chronic pain. Nowadays, we very much believe these things to be real. They're not made up. They're not just depression, which a lot of people thought, or they're not just people trying to get attention or getting secondary gain. We believe this to be true. Okay, now I want to talk about this condition called hyperalgesia. Hyper meaning too much, algesia meaning pain. So like an analgesic medication is going to help stop pain. Hyperalgesia is way too much pain. And I want to talk about some of the research on premature infants, and we're not going to get into the ethics of this because we could spend a whole course on the ethics of this. But I want to talk about the research on the premature babies, on these surgeries on premature babies, and then we'll kind of back this up into a big evolutionary understanding of how some people can their bodies learn through conditioning processes, their bodies learn to be more sensitive to pain. Okay. So you got these premature babies that are in need of some kinds of surgical procedures. And in one of the studies that they did, they randomly assigned these premature babies So that half of them had surgery without anesthesia. And keep in mind, anesthesia is dangerous in and of itself, which is why when we get put under, we've got an anesthesiologist watching us the whole time when there's a surgeon or surgeons performing the other surgery. So full-time anesthesiologist watching us as they put us under, making sure they don't kill us with the anesthesia. But it's dangerous, okay? And so you've got half of these babies who aren't getting the anesthesia during their surgery, and you've got half of these premature babies who are getting anesthesia during their surgery, okay? And again, premature babies aren't going to be complaining, so we don't really necessarily know what they're going through or what they're not going through. Assuming these babies survive and they live to go on into, you know, infancy, childhood, and later life, the ones that did not have the anesthesia, meaning they were probably feeling pain while they were having this surgery, they are more sensitive, more likely to have hyperalgesia, more sensitive to pain later on in life. The babies that were anesthetized during their surgery, they later on in life have what we would consider to be normal levels of pain sensitivity. And so what seems like it can happen for us as humans, experiencing this physical pain in one way can sensitize us to more pain in another way. I'm flipping around here to try to see something. Okay, I'm going to back up and make a point right here then. Okay, so we think pain is necessary for life. There's evolutionary adaptation. I want us to think through evolution and kind of think through this idea about the fact that some people could condition and learn more pain sensitivity. So imagine we're back in cave people times in evolution, and the thing that would take us out would come from the sky. So there's like pterodactyl like birds, and you know, we're out picking berries and hunting and whatever, doing what people did back then, and a flock of these pterodactyls come in, and they're rah, 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 and they come in towards the head, and they try to take out our eyes, because they learn if you get them in the eyes, they, you know, it takes the humans down, and if you take the humans down, they can come in and they can eat and feast off of us. If that had occurred, if there'd been head injury because of one of these birds, wouldn't it make some sense that we would become super sensitive up in this area of the body? So that if we're out there doing our cave person thing, picking berries, and one of these birds flies over and we just feel the wind of it, like, oh, super sensitive. We know how to protect ourselves. We know how to duck and get away from it. Okay. Flip the story. Imagine we're cave people, I don't know, way back when, and the thing that is really dangerous for us is there are these like rabid rats that want to take us down. So they get us at the feet, they bite us, and then we, you know, get all preoccupied and we fall over. And after we fall over, all the rats come in and they attack us and they eat us and they feast. Really gross, I know. But just imagine that. Imagine that's the scenario where the danger is at our feet. And we have been bitten before, but we were able to shake it off and run away. Then imagine if our feet got really, really sensitive to any kind of wind or movement or creepy crawly kinds of sensations. Wouldn't that be adaptive? That the quicker that we could learn to react if there's a sensation at our feet, the more likely we would be able to survive. So what I'm getting at here is that some people seem like they can actually learn pain sensitivity. And we think there has been evolutionary adaptation over time because of that. Okay, big word here, nocioception. Get this in your notes. We're going to understand what nocioception is. So nocioception is, I want you to imagine that I've had an injury to my hand. So there's an injury there. I can see it. It's all yucky and it's bloody and that kind of thing. Is the sensory stimulation that is going to happen from that injury, from the tissue, either externally or internally inside the tissue. And let's say that's real injury, cells have been broken. And as cells have been broken, their insides come out and they release chemicals. And so there's this chemical release from the damaged cells. And then now there are certain parts of these cells that can marry and get together and synthesize. And when they synthesize, we call these things prostaglandins. And prostaglandins have the ability, after they have synthesized, to lock into a nerve and send that nerve signal. Okay, so we've had nocioception is the stimulation in the injury area. Cells get damaged, they release chemicals. Some of those chemicals synthesize, we call those synthesis prostaglandins, and then those prostaglandins send a nerve signal. Okay, so I'm going to use an example here of taking an over-the-counter analgesic like Motrin as an example, which is, or Aleve, which is quite effective for a lot of women when they are experiencing painful menstrual cramps. They take those medications, and the way that they work is they stop the prostaglandin synthesis. So imagine, okay, here's the uterus, and uterus is cramping, which is that sensation that women feel when they're having their menstrual periods. You guys, I hope you're learning something here. You gals, you're all like, yeah, okay, I get it. So the uterus is cramping, and you take these over-the-counter analgesics and they interfere with the prostaglandin, that synthesis. They stop that synthesis from happening. So then the nerve signal, if the synthesis doesn't happen, the nerve signal doesn't get sent. That nerve signal being that kind of crampy sensation. But the uterus is still cramping. It's not like you take this stuff and then it stops cramping. That would actually be dangerous because we got to get that endometrial lining out of there when there's no baby using it. So the cramping is still occurring. She's just not feeling it in her abdomen. Okay, so a lot of those over-the-counter medications, that's how they work. They stop that prostaglandin synthesis. All right. Okay, so let's say all of this has happened, and now there is a nerve signal that is going to the spine, and then the nerve signal has the possibility of traveling up into the spine. But I want us to think about where the spine enters the brain. It is going to enter the most primitive part of our brain. This is the most advanced part of our brain. We're the only mammals with these big, huge foreheads out of evolution, because this is really like what makes us a human being, and this is what makes us an animal. So it travels up the spinal cord. It enters into the most primitive part of the brain first, which is why we have really primitive reactions oftentimes to pain. So we get hurt, we yell, we cry, that type of thing. We react if there is danger, in those reflective, instinctive types of things. And then it's after it goes to the primitive part of the brain first, then it's got the possibility of coming over to more complex, more modern areas of our human brain. And then we get signals bouncing back. That's the reflective stuff. But what I really want you to register here is that nocioception, which is the signal that starts anywhere at the point of injury, to getting all the way to the brain, is both a neurological, nervous system, and a chemical process. So it's neurological, electrical, and it is a chemical process, and it works in these segments. Okay, it works in these segments. And so just because we have an injury right here is not a straight nerve shot up to being perceived at the brain. It is happening in different chemical processes, it's happening in different nerve signal processes. And then we've got this whole modulation that is happening at the level of the spinal cord. And we'll talk a little bit more about gate control theory here in a bit. And we think gate control, the whole gate is at the level of the spinal cord. Okay, so this gives us some understandings of how medications get in there, and they can both affect the nerves, but a lot of times the medications are affecting the chemical process of the nocioception. Okay, an important definition part of the nocioception is that just because you have had a certain thing happen to tissue, the nocioception, the way it gets interpreted in the brain, for one person, it could get interpreted as very scary pain, as an example. And for another person, it could be interpreted very differently, of like, oh, that's weird. That's a weird sensation kind of thing. So I like to use the example. Imagine if you were a little kid and you had siblings that were mean to you, and your siblings used to tickle you, and especially, they'd get the most like laughter out of you by tickling your abdomen, as an example. And if you're the one who's being victimized by the tickling, you might be laughing, but it doesn't actually really feel good. It makes you laugh, but it was really irritating feeling. Okay. So you've got this stuff happening on your abdomen, and it's like, oh, yuck, that feels awful. Flip that. Imagine you are with your loving sexual partner and there is certain type of touching on the abdomen. In that context, very similar types of sensation is now oftentimes, if you are open and willing and ready, would be interpreted as like, "Ooh, ooh, baby, let's go." Okay, this, so it's more of a sexual kind of feeling than a tickling kind of feeling. So not all nocioception gets interpreted the same way in the brain by different people, and then even within the same person, not all nocioception necessarily. Okay, so some other textbook definitions here, other components of pain. Pain is a psychological sensation from the interpretation of nocioception. So the psychological sensation from the interpretation of nocioception. Suffering, on the other hand, would be when the emotions in the brain are now involved, because this feels like, oh, this is bad, this is pain, would be the emotional experience based on the interpretation of the nocioception. Pain behavior it can be reflexive behavior, but it's the behavior that we engage in as a result of the nocioception. And a lot of times pain behavior is meant to relieve pain. So you've got tight muscles and you rub them and then it's like, okay, it eases the pain. I would ask you, if you were live in class, where's she hurting? And you all would go, she's hurting in her stomach or her abdomen. And then I would say, diagnoses, what are possibilities here? And some of you would probably say, oh, maybe appendicitis, or some of you would say she's being really dramatic about those menstrual cramps, or whatever, or maybe she's got ovarian cancer or something like that. But based on her pain behavior, it communicates to others. So we would know, even if she couldn't talk, if we were a medic as an example, we would know where to look for problems in her body. As well as pain behavior for ourselves oftentimes does things to help us ease pain. Okay. So as an example, a lot of women know this, guys, you're learning, know that when they have painful menstrual cramps, when they sleep, if they sleep on their back, it tends to be a lot worse. If they're capable of sleeping on their abdomen and putting pressure on that pelvic area, that oftentimes that eases menstrual cramps during sleep, as an example. Okay, let's talk about gate control theory. Now, let me move my little thing. Mel's and Walls, they're pictured here hanging out on the bench talking about gate control theory. This is a very old theory, but it is one of those theories that has held up across time. And the theory here is that nocioception at the tissue site is not straight through pathway to the brain and being interpreted as brain, that the spinal cord is really the part of the body that modulates signals. And so let me talk about the highway analogy, and I think this will bring some things together for you all. Okay, so imagine we're on I-40. Most of you have been on I-40 at some point in your life, and there are 4 lanes. So you've got 4 lanes of traffic going in one direction. Now imagine if the 2 outer lanes eventually close and merge into the 2 inner lanes. But I want you to think about it this way. In the real world on a highway, everybody merges. Everybody just has to slow down at that merger point. But imagine if in the highway scenario, if you're on the outer lanes and they close, you're stuck there. You don't get to go through. No more traveling for you. Only the people who are lucky enough to be in the middle lanes, they get to go through. Now I want to go back to that paper cut analogy. So paper cut, you've got these stinging signals that are all competing to get through the highway, and then you add in their pressure signals. The pressure signals somehow have the advantage on the highway. The pressure signals are able to make it through the highway, but when they make it through, now there's not enough room on the highway for the stinging sensations to get through. Okay, grasp this. I want y'all to grasp this type of thing. So either certain signals get through the gate, make it through the highway, those middle lanes, and get to travel all the way up the spinal cord into the brain. Or in some situations, we can do certain behaviors and send certain signals through that are more likely to make it through and then thus block other signals. Got it? Okay. So, okay. So we could either think of it like a drawbridge, or we could think about it a gate that opens or closes. Any way you want to think about it, it really doesn't matter. But I just want you to know that certain signals have the capability of being stopped and blocked at the level of the spinal cord and not making it through. And then when we think about a lot of those pain behaviors that we instinctively do, it's because we're sending through some other signals that kind of make their way and help us not feel pain. Other things that we have done that can do this, TENS device. There are probably some people in our class that have either used a TENS device yourself, or you've got relatives who have used a TENS device. And this is transdermal electrical nerve stimulators. We've got these things that people put on the outside of their muscles and their tissues. There's certain devices that actually get implanted within the spinal cord or get implanted within the brain. And then what these devices are doing is they're sending through various types of electrical signals. And a lot of times when people use a TENS device, they put on the electrodes, and then they actually even play around with the electrical possibilities of the device until they reach a sweet spot. And the sweet spot would be where they're sending through enough of the right kind of electrical signals where whatever pain sensations they would normally be feeling without the TENS device feels like it stops. Okay, so they're deliberately sending through electricity on the highway that has the capability of making it through, so that the nocioception that is being interpreted as pain is not making it through. We also use hypnosis. And hypnosis is, again, we've talked about this a bit before, very deep relaxation and meditation, where you are then adding to it suggestions that make it easier for individuals to cope with their either acute pain or cope with their chronic pain. So one example would be, let's say a person has intense back pain, and we imagine the person in their hypnosis to go in there and actually picture the back pain as if it's not this steady stream of pain, but it's almost like a boogie board or a surfboard riding in the ocean, riding a wave. And as it rides into the ocean, there's less and less water, there's less and less pain. And then imagine the water receding and the pain ceases. So instead of it just being this intense constant, it's like on a wave. It's got the capability of coming down and dissipating and going away. Another example is I worked with an older gentleman at one point, and he had tinnitus. So he had that ringing in his ears, which drove him crazy. It would kind of disturb his thoughts during the day. It really, really bothers people when they're trying to sleep at night and they hear that ringing in the ears. And in hypnosis, what we did is he was able to visualize what he thought was going on in his inner ear. And he imagined these little things that were vibrating and sending out sound. And then what we did together in hypnosis is he built a soundproof booth, and he even put the the absorbent egg carton kinds of spongy stuff inside, insulating the booth. And then the last thing he did in hypnosis would be, after he built this booth around those little things that were vibrating, he shut the door. And then the ringing, the tinnitus stopped. So we do all kinds of different creative things in hypnosis. You saw a bunch of those examples in cases in the New Medicine documentary that was doing that. Physical therapy and chronic pain. I know we've got some pre-PT people in our class. We probably have some pre-OT people. Physical therapy is doing strength training, exercise, doing stretching to rehabilitate damage in the body, protect the rest of the body, make sure you're not damaging something else when you're healing other parts of the body. And then physical therapy spends a lot of time focusing on symmetry. Or if you have injured your right knee, then your whole left leg has probably been overworking because your right knee's been injured. How do we get the right side of the body strong again so that right side and left side are working with equivalent flexibility and equivalent strength? And then what physical therapists tend to do is assess their patient, look at what they're capable of doing, either have them do exercises under their watch, or have them do exercises and rehab at home. And then they go back to the physical therapist, and then they're usually able to bump it up a notch because they have been able to improve different things over time. The SPA stuff, that's the same thing as the TENS device, but that's when you've got a medical professional either putting it into the spinal cord or putting it into the brain. And there are actually people who get some major relief from that kind of stuff. Okay, so the chemical intervention, and basically let me start out by saying we got lots of different chemical interventions. This does so much better with acute short-term pain than it does with chronic pain. Okay, and again, health psychologists focus a lot more on chronic pain. We'll talk about why here in a bit. So the opioid analgesics, also called the narcotics, tend to create numbness for pain, which is why they are used. And for a lot of individuals at the level of the brain, they'll create an indifference to the pain, or here's where we get into trouble, when they create a euphoria for the pain. I still remember my younger son coming out of his wisdom teeth surgery, and he was kind of excited knowing that he was going to get these drugs. And he came out of his oral surgery for his wisdom teeth, and I was so pleased the doctor and the nurses weren't around, because I can't believe what came out of his mouth. I'm not even going to tell you. But he was fascinated with the feeling. He was sort of fascinated with being under, fascinated with the waking up. He was fascinated with the feeling. He was feeling good. And I remember having this, like, kind of like as a mom response of like, uh-oh, he likes this stuff. He's fine. He's not abusing narcotics at this point. Okay. So the opioid analgesics, they bind with central nervous system receptors, which we have absolutely all over our body and in our brain, which is part of the reason why they can be so addictive, because they can make pain go away. Okay, so that is actually positive punishment, making the pain go away. But then they can feel like that euphoria piece can be considered primary positive reinforcement. And again, we get that. Remember, we talked about in the nicotine, tobacco, smoking cessation lecture, opponent process. Oh, yeah. These opioids very easily will condition to that opponent process, which is why if people want to keep getting that same effect, tampering the pain, feeling that euphoria, they will be taking more and more and more, because the opponent process keeps taking it down and down and down, and very addictive. So you hear stories about people having a surgery, having narcotics afterwards, and then getting more from their doctors, or becoming psychologically, physically addicted, and then black market getting their medication. Where people are really getting in trouble right now in the opioid crisis is people who've moved on from prescription meds to either getting black market prescription meds or moving over to heroin, very, very dangerous, highly addictive. And then where people are really getting into danger is if they're accidentally getting fentanyl when they're trying to use heroin, which is so much more potent and then has the capability of stopping the respiration and killing people. And it is killing people. So really sad epidemic that's going on out there. The non-opioid analgesics are the over-the-counter kinds of things. So the NSAIDs, which are non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs. So there are steroids, corticosteroids, that will quell and get rid of inflammation, but these are the non-steroidal ones. They don't create sedation like the opioids can make you woozy and make you want to be sleepy. They do reduce inflammation. They can reduce fever, and they can also, the aspirin type will inhibit platelets and blood clotting. And these all are blocking that prostaglandin synthesis at the tissue site. So the menstrual cramp example, the women aren't feeling the cramping, but the cramping is still actually occurring. The COX-2 inhibitors are these prescription medications that were developed to be a little more powerful than NSAIDs. They tend to have less stomach irritation. The NSAIDs, if you take them, for a lot of individuals, if you take them over time, a lot of individuals will report they feel like gastritis, they feel yucky in their stomach. A lot of people will get nauseous on them. They create stomach irritation. They can actually, chronic use of them can burr through stomach wall and create ulcers. So basically in this chemical intervention, there is nothing that is ideal chemically that has been a miracle, especially for chronic pain. Okay. I am going to end part 1 here before we get into treatment. What we have covered in part 1 of this pain lecture is really understanding acute pain and understanding chronic pain. Where we're going to go in part 2 is all about treatment. So I'm going to pause now. If you all have questions, again, we'll open the forum on As You Learn for that. But I will cease part 2 and I will see you back here in a bit.